Good afternoon, ladies and gentlemen, and welcome to the American Enterprise Institute. I'm Naomi Schaefer Riley, a senior fellow here, and I focus on the issue of child welfare. Here at AEI, we are committed to finding solutions to help the most vulnerable members of our society, and children who have suffered abuse and neglect at the hands of their caregivers are, of course, among those most in need of our attention. As many of you know, up to 90% of families involved with the child welfare system are suffering from substance use problems, alcohol, or drugs. When I interview foster parents in my work, they are often hard-pressed to think of any children they have cared for whose families have not been dealing with alcohol, drug use, and or co-occurring mental illness. It would not be an exaggeration to say that the drug crisis in this country is actually driving the child welfare crisis. Pediatric poisonings are up, unsafe sleep deaths related to parental intoxications are up, young children are being left unsupervised for hours or days while their parents get their fix. Across the country, tens of thousands of children are being neglected by parents who are too affected by alcohol or drugs, unfortunately, to be responsible for their care. Researchers suggest that between 400,000 and 480,000 children born each year have been prenatally exposed to drugs or alcohol. Unfortunately, even if these children do come to the attention of authorities, and there is increasing pressure from activists to ensure that they do not, kicking drug addiction is hardly a guarantee. I have met parents who were in and out of rehab for over a decade while they were trying to care for their children. Their children's lives were an endless cycle of abuse and neglect, foster care, reunification, and abuse and neglect all over again. Even in regions that have enough rehab beds, there are no guarantees. In 2021, former New York Times reporter Andrea Elliott published a book called Invisible Child about Dasani, a young girl whose family had been involved with the child welfare system for decades. During the course of Elliott's story, Dasani's mother and father enter at least a dozen different treatment programs, both residential and outpatient, and they seem to have no trouble getting into them. But no sooner do they get clean than something goes wrong and they return to using. Agencies and courts are constantly forced to judge the likelihood of relapse for these parents who do take initial steps toward getting clean. It is a terribly difficult call. We have been doing this for decades without much innovation, but there are glimmers of hope thanks to some new addiction treatments and programs, and that's what we're here to talk about today. So I'm excited to welcome Alex Jutca. Alex has been the director of the Office of Analytics, Technology, and Planning at the Allegheny Department of Human Services since August 2021, where he oversees data analytics and research, software development, strategic planning, and new program incubation. He came to DHS from Seattle, where he built a data science team developing large-scale statistical models and algorithms at Amazon to optimize the company's operations. Prior to Amazon, he was an associate director at Social Finance, a Boston-based nonprofit dedicated to scaling high-quality, evidence-based nonprofit service providers. After Alex presents to us today, we'll hear from two experts in the field. First will be Ron Richter. He is the CEO and executive director of JCCA, an organization that provides foster care, residential treatment facilities, mental health services, case management, education programs, and special services for children who have been victims of sexual abuse. He is a former New York City Family Court judge and former commissioner of New York City's Administration for Children's Services. Then my colleague Sally Satel will present. She is a senior fellow at the American Enterprise Institute and has been a staff psychiatrist at Partners in Drug Use Rehabilitation and Counseling since 2010. She is a practicing psychiatrist and lecturer at the Yale University School of Medicine and the author of numerous books. Following Sally and Ron's responses, we will have a discussion and questions and answers with the audience. So without further ado, here's Alex.
Thank you, Naomi. So I'm going to talk about three things today with you. First is I'll give a brief overview about the Allegheny County context and some of our challenges with substance use. I don't think that any of them are highly specific to our county, but I think it's a great jumping off point to talk about these issues. And then really going to focus most of my attention on thinking about ways that we can innovate, both in terms of treatment efficacy, so that is how effective is what we're recommending to people with substance use disorders, as well as how we improve on treatment engagement. And I'm going to argue that I think we really need to improve on both those dimensions to really put a dent in addiction in the United States. So Allegheny County is a 1.25 million person county in southwestern Pennsylvania. In our Department of Human Services, we have federal, state, and local funding that we braid together to run integrated programming. So our total budget of about $1.4 billion allows us to run programs ranging from the child welfare system to the behavioral health treatment system, services for older adults, the homeless housing system, early intervention, so on and so forth. One of the things that's really come with this integrated department is also integrated data, which I'm going to talk to you about. It's allowed us to really understand how our clients are progressing across many of their these outcomes in these domains, which I think are highly overlapping. So here's just a snapshot of what child welfare looked like in Allegheny County in 2022. We received about 15,000 referrals of children for abuse and neglect. We investigated about half of those, so about 7,000 of them. We opened cases on somewhere around 12 to 13% of them, so somewhere around 900. And then in total in 2022, we had about 1,200 dependency filings and around 730 new home removals. So what does our child welfare substance use disorder practice looks like? I think that this is somewhat common to what you'll see across the country, but all births with positive toxicity screens will come to child welfare's attention. Our caseworkers that go out into the field to investigate claims of abuse and neglect are using early identification techniques of families at risk for substance use disorder. They're interviewing, they're doing on-site visits, they're conducting home assessments. If they flag an issue for substance use disorder or a concern, they will make referrals to a contracted provider that does a level of care assessment. And what that level of care assessment really sort of unlocks is slotting families with substance use disorder into the right level of service. So whether that's outpatient or inpatient or withdrawal management or what have you, that's where that sort of flow kicks off. In Allegheny County, we're incredibly lucky in the sense that we have really excellent behavioral health treatment service access. We've got services that really run the gamut from highly bespoke drug and alcohol providers to large integrated health providers that run the gamut across mental health and substance use disorders. And so in some ways, I think we are quite fortunate on that dimension. Within child welfare, once somebody is attached to services, we are requesting treatment verifications from our providers, and then we'll do things like random urine screens where appropriate. So as Naomi was mentioning, opioid use and concerns are incredibly prevalent in child welfare. So what you see here in this table is really 3 measures of opioid use and abuse, and then at 3 different stages of the child welfare system. So at case opening, with those with a dependency petition, and for children who are removed from the home. And 2 of the 3 ways that we're going to think about opioid use dependency here is around claims data. So were you actually diagnosed formally in the behavioral health treatment system? Did you actually receive medication for opioid use disorder? And then last, we're going to look at the case notes that we get from caseworkers where they flag issues related to things like domestic violence or drug abuse. And I think that that's an incredibly rich data source that sometimes goes underutilized here. And so what you see is that across child welfare, somewhere between 1 in 5 and 1 in 4 parents have a known diagnosis for opioid use disorder. But if you look sort of more expansively at case notes that will mention concerns about opioid use, you get a fraction that's closer to 2 out of 3 families that are have a case opening in the child welfare system. And as you get further along the child welfare system, such as dependency petitions and removals, that fraction tends to inch higher. This is important because not everybody who has something like opioid use disorder is formally diagnosed. Not everybody is treatment seeking. And so you should think about the opioid use disorder sort of prevalence as a strict lower bound on what the real need is. And I think that 2 in 3, 3 in 4 estimate gets more to, I think, is more in line with what Naomi opened us up with. Another way to think about this is that in the state of Pennsylvania, child welfare agencies are responsible for looking after all child fatalities and near fatalities that happen due to abuse or neglect. And what you see here in this graph is really that figure decomposed by sort of two different ways of looking at the data. One is drug ingestion. So children can die or nearly die from drug ingestions, but they can also die from other reasons, and those other causes might be things like head trauma, for example. And so the ingestion data here is the sort of the royal blue bar that you're seeing. And really, up until 2016, these things were incredibly rare and very sporadic. Right around 2016, you start to see this sort of exponential jump in terms of the rate of increase of ingestion events. And they now comprise fully half of the fatality, near fatalities that we're getting in the county. 2016 is really significant for us because that's when you start to see fentanyl, a highly potent form of illicit opioids, really sort of infiltrate the drug supply. And so I think that this just speaks to the concerns that not only is this prevalent in child welfare involved families, but this is also prevalent early on for children, whether or not they're actually involved with the child welfare system. So broadly, Allegheny County kind of looks like our peers in terms of fatal overdoses, sort of broadly. So right here, what you're seeing is Allegheny County plotted against some of our peer jurisdictions, so Baltimore and Philadelphia. Overall, we have a lower overdose rate than those two jurisdictions, but we've seen sort of a sharp increase since 2014 in terms of the fatal overdose rate. For Black individuals specifically, we're seeing a rise in fatal overdoses. When we dig into the data for that group in particular, what we tend to see is this overlap between opioid use and stimulant use, this idea that maybe things like fentanyl are really infiltrating the supply of cocaine or methamphetamines, and this has become particularly toxic and dangerous to folks who are using those drugs. So despite the problem and the massive amounts of investments that have been put into expanding access to treatment, the take-up of gold standard medication for opioid use disorder remains a huge challenge. And so there are three major medications that are approved for opioid use disorder. On this particular figure, I'm showing the most commonly used, which is called buprenorphine. And what this is plotting is the share of individuals in Allegheny County with opioid use disorder who have ever received buprenorphine in that year. And so the good news is that this rate has actually increased over the past decade. It's gone from about 15% to 20%. The bad news is that there is no upward trend, and there is no apparent way in which we're going to get to mass population health benefits of taking up this medicine. And that really presents to us, I think, a huge challenge of how we could, and if we can, actually raise that rate. But of course, we're not just interested in getting people to use medications like buprenorphine. Once they're there, we really want to see them kind of continue on and use those medications. Some people can be on medications for the remainder of their lives. But most of the quality assurance metrics that we think about at the public health level are looking for something like 6 months of continuous utilization. And so what this graph is showing you is a survival curve over time for each of the three major medications that are used for opioid use disorder treatment. And what you're seeing here is that fully half of each of the recipients of these medications are falling off, are discontinuing medications well before the 6-month threshold. And in particular, a lot of the fall off for folks is happening quite immediately after their first receipt of medications for opioid use disorder. And again, I think that this really sort of presents a strong challenge for us about how we're going to address that gap. So with that, I really think that there are three potential paths forward here. Innovation on treatment efficacy, so how do we get more effective treatments for addiction? The second is how do we actually spur innovation on treatment engagement? So how do we get more people to take up effective medications and stay with them? And then last, there's really the path that I don't think anybody wants to see, but I think is a real possibility, which is addiction burns out. Our best solutions to the opioid epidemic, frankly, have not been good enough. So recently there was published in the New England Journal of Medicine, the NIDA-funded Healing Community Studies. It's an evidence-based community-chosen intervention, so communities will choose which of portfolio of options they want to pursue, things like naloxone medication, things of that sort, to kind of invest in their community. This happened in 67 communities across 4 states. It was an incredibly ambitious and major initiative, so a $344 million investment to make this a reality. And the results were not good. So they were not able to find any difference between the treatment and the control group here in terms of fatal overdose rates, which I think is quite disheartening. Similarly, in terms of bleak pictures of what's happening on addiction, our rate of medical innovation has just been very stagnant. And so what you're seeing in this table is for stimulant use disorder, alcohol use disorder, and opioid use disorder, how many new novel treatments that have been approved by the FDA since 2000. What I mean by novel here is not reformulations into longer acting versions of an existing drug, but truly new drugs with a novel mechanism of action. And for opioid use disorder, we've seen one new treatment approved by the FDA, that was Suboxone, all the way back in 2002. For alcohol use disorder, that was acamprosate in 2004. And for stimulant use disorder, we've approved none. And there still today remain no FDA-approved medications for the treatment of stimulant use disorder. This is incredibly significant by the fact that over half of the deaths due to overdose deaths due to opioids have a co-occurring stimulant in them. And so I think really to make progress on the opioid epidemic, you're also going to want to think about effective treatments for stimulants too. I think one of the most interesting things that's happened recently is that GLP-1 agonist drugs like Ozempic have come to the fore as a potential very efficacious treatment for addictions of all type. So there have been recent small-scale randomized trials that have shown strong reductions in things like craving and consumption of alcohol and opioids. So that's work by Christian Hendershot at the University of Southern California and Sue Grigson and colleagues at Penn State University. There's been a recently published retrospective study in addiction that's found decrease in overdose and alcohol intoxication risk from the use of these drugs. The patient anecdotes here are pretty fascinating. So there's a subreddit called Dryzempic on the website Reddit, where you sort of see all sorts of pretty organic stories. I've just sort of clipped one here where this person sort of saying that people are telling her that it's her higher power in AA, and she's saying no, she really thinks that it's these drugs. And the patient appeal here, I don't think is to be neglected. So when you think about the other drugs that I showed you, they're often not just highly stigmatized, but I think have difficult initiation procedures. They're highly regulated. In contrast, when you think about GLP-1 drugs, you're thinking about low side effects, high efficacy, unrestricted access. There's no abuse risk. There's no stigma. And so I think that these hold a great deal of early stage promise. I think one of the things that's been striking to me, though, is that it has not been obvious that the patent holders for these drugs are going to pursue an FDA indication for addiction. And so that really, I think, societally presents this challenge where how can we actually make progress on these issues? So with some of my collaborators at the Center for Addiction Science Policy and Research, we're sort of trying to develop and execute a phase 3 pivotal trial for GLP-1s and addiction that would allow us to get an indication, really build critical evidence on the efficacy of these things. And we're working with, in early stage with the VA here, who have been absolute pioneers on many problems related to behavioral health, given the overlap between veterans and substance use disorders. And I also think that there's a broader opportunity here, not just to study these things sort of for clinical efficacy, but also to think about their application in settings like child welfare, like homeless housing, many other settings where we think about the negative consequences of addiction as washing ashore in pretty profound ways. But beyond innovating on treatment efficacy, I do really believe that we're going to have to innovate on engagement strategies here to improve medication adherence. And so I'm going to give you guys one example of something that we're working on outside of child welfare that I think has lots of implications and applications to the child welfare setting. So Here we're thinking about involuntary hospitalizations, and just as a little bit of background, every state in the country has a law in the books that allow people to be committed to involuntary hospitalization when they're at risk of danger to themselves or others. The problems with this group in terms of adverse outcomes are astonishingly bad here. So we're seeing about an 8% death rate in year after discharge from hospitalization. That's much higher than comparable rates that we're seeing for individuals coming out of the jail or our homeless shelters. As far as controllable inputs, medication adherence here is very poor, so about 20% in the year following a hospitalization. I don't think anything close to what clinicians would hope to see. But there is, I think, some hope in the sense that there's been consistent evidence on how financial incentives help to rewire people's reward system and really change some of these incentives so that people can stick with medications. And so the question we're interested in asking is, can we pay people to take longer acting medications to mitigate the risk of negative outcomes after involuntary hospitalization? So that is, pay people to hang with medications, to continue to come back to clinics, to be on these things long enough to stabilize and hopefully avoid some of these adverse outcomes. We're doing this in partnership with one of our largest psychiatric hospitals in the Pittsburgh area, and this will be the first trial in the United States to really sort of test this. But I think a lot of the principles in terms of thinking about clever ways to apply incentives to hard problems, I think are consistent across many different settings. Quickly, I'll go through some other opportunities to innovate on engagement that really, I think, jump out to me. The first is that I think in other settings like street medicine, it's incredibly common to see outreach to the homeless for reasons related to substance use disorder or psychiatric illnesses take the form of really persistent, really convenient engagement where a clinician will show up daily. If they're told no that day, that's not a deterrent to them. They'll come back the next day. They'll hang with that person. And I think that type of persistent outreach approach isn't broadly scaled within the behavioral health treatment system, and I think it's one thing that strikes me as a potential good opportunity to go out and test in the child welfare system. The second is really legal options for mandated treatment that could be in child welfare related, but there's also laws like assisted outpatient treatment that really are sort of medication adherence focused, more on the psychiatric side, just mental illness side, than on the addiction side. But I think many of these clients might benefit from that. And then there's also the concept of prevention before child welfare involvement. So earlier when I showed the graph of fatalities and near fatalities of young children, one of the things that I didn't mention is that about half of those deaths are happening before child welfare has an opportunity to intervene at all. So how do we sort of swim upstream here to address these issues before they materialize? And on this, the county has been incredibly innovative in developing a program called Hello Baby. And Hello Baby offers tiered supports to every new parent in Allegheny County. And we're tiering parents based off of likelihood of child welfare involvement, so trying to really be strategic in terms of how we offer services. All of these services are completely voluntary, and they're universal, so everybody's able to get something. At the very top, in terms of risk, we're offering highly hands-on, lots of service coordination, lots of outreach. In terms of the middle tier, you're thinking about things like access to concrete goods like diapers and wipes. And then at the lower part of it, you're thinking about just universal outreach so that parents know where to turn for help, that they know where resources exist. And so the program's a couple years old at this point, and it's been incredibly exciting to see how many families we've been able to engage with. And I think that type of model bears a great deal of interest and potential. So I'll close on this. We won't solve addiction unless we try. So I think business as usual is clear that it's not going to do the job for us. Addiction is a super persistent challenge in child welfare. Medication utilization seems to be one of those controllable inputs that's a tractable path to better outcomes here for individuals with serious mental illness or addiction. investment in service access in a place like Allegheny County that is relatively resource rich, and I suspect in many larger jurisdictions, larger counties, more urban areas, it's unlikely at that point to be something that's going to be a significant lever for reducing the harms from addiction at this point. Experimenting with new delivery models, I think, is especially promising. So we touched on a number of them: financial incentives, upstream prevention, convenient and persistent medication delivery services, involuntary care. I think there should be more experimentation on these and more good data to provide a sense of what's actually working out there and where can we actually scale some of these things for true population health impact. And then lastly, no new medications for addiction in 20 years can and must change. We think that this GLP-1 opportunity is immediate, but I think thinking longer term at the federal level about how we can change the incentives for innovation here, I think bears a great deal of scrutiny and promise. So thank you.
All right, Ron?
Sure. So good afternoon, everyone. My background is primarily in child welfare, both as a family court judge and managing New York City's public child welfare system about a decade ago for a few years. I would say that the most challenging kinds of cases, or the families that present the deepest challenges for us in child welfare, generally have three things going on. There's some sort of mental health challenge, depression, anxiety, maybe something more serious than that. That results in a parent, usually in the most difficult cases of 2 or 3 children under 5 years old, struggling as a result of their untreated mental illness with self-medicating. So drugs and alcohol get introduced. Very frequently, there's also some level of family violence. So I would say that those are the most difficult cases for individuals trying to make decisions, whether that's caseworkers or judges, lawyers in this context. I find any effort to be innovative around treating these families tremendously positive. After more than 30 years of doing this work, we still have chronic addicts struggling with trying to get their children back. And we really haven't come up with many solutions. Some people think that if we offered more comprehensive behavioral health care to families earlier on, upstream, that we would see the results of that. And I agree. In my 30 plus years, there's never really been availability and access to the extent that we're seeing a real benefit. You have to be very motivated to go to behavioral health services, and when you have 2 children under 5 and you're managing a household, it's not easy. So the question becomes, for those cases that are really serious, where the likelihood of returning children is small, are there ways for us to incentivize the use of various treatments? I recall that in New York City, a little more than a decade ago, we introduced an evidence-based model of parenting support called Parenting Through Change. And part of that model was to pay parents to come to essentially parenting circles and parenting skills supports. Those, I would say, were well received by parents who felt like they had an extra motivation to engage in services. Judges and lawyers were highly critical of even giving a parent $20 per session that they attended, even though it's demonstrated that that does get parents to come to the sessions. And in fact, many parents buy stuff for their kids with the $20. So it makes sense, but I raise that because there's a cynicism about actually trying to support families with fiscal incentives. I think we kind of have to put that to the side, because if something works, we need to use it. Clearly, the costs to society and to our system of trying to figure out the right way to reunify a family safely requires more innovation than we have right now. So all of this to say that I think that any innovation, especially one that's science-based, is welcome. The last thing I'll say is that the child welfare workforce struggles already. So we've been struggling. So we're talking about the caseworker who responds to the call, goes out to the home, knocks on the door, and investigates allegations. That person has a dual role of not only investigating, but also trying to engage. And I would say that any innovation that we bring to bear needs to take into consideration how it's operationalized, because it's complicated stuff and it needs to be explained to a workforce that is going to then explain it to customers. And there's a lot of complexity there, because workers in child welfare tend to be generally overwhelmed, ridiculous amount of paperwork, maybe more than 60% of their time on paperwork. And so I just want to raise the caveat that we need to talk about how we're implementing these various incentives in order for them to maximally work.
Great. All right. Sally?
Well, you've picked out the two biggest problems, except for Mexican cartels, I suppose, but, confronting
You can get to that next.
the drug problem, which is how to engage people in drug treatment and how to keep them there. Because one of the very true and important rules of thumb is that the longer you stay in a treatment program, the better you do. That's almost like a golden rule of drug treatment. And so these things are hard, and you have my sympathy. So I'm going to talk about why it's so hard to engage people and why it's so hard to retain them, which is, I would say, the precursor to coming up with solutions. And many of yours, I think, are exactly the right approach to take. I also just want to make some comments towards the end that there's just so much investment can make in the biological approach to this problem. It's necessary, but it'll never be sufficient. I know you know that, but sometimes when I hear people, some policymakers talk about this issue, they seem to see these almost as magic bullets, and that is just not going to happen. So I know that from working in a methadone clinic where we have the magic bullet for craving and withdrawal. It's called methadone, and it really helps, but it's not enough. A lot of our folks still continue to use drugs, admittedly at far lower rates. So it's always a win, really, from a strict accounting standpoint. You will, when you're on these medications, you will use fewer drugs. You will show up in the emergency room less often. If you have a job of some sort, you will go to it for more days. You'll be arrested less often. And that's from a population-based analysis. That's all valuable stuff. So let me start with why it's so hard to engage people. And first, there's nothing, as I think you mentioned this, there's nothing unique. Oh, you said that addiction among in the child welfare system is really not that much different from addiction everywhere. Well, I would take that analogy to a higher level and say behavioral change of any kind is really hard. So, and addiction is just a behavior, and it's hard to change. And people, they say they want to change. Sure, a lot of them do, but what they mean is they don't want the consequences of their drug use. And which is a little different from having it's a lot different from having the motivation to go through the steps. You also mentioned that it's hard to engage folks, but I mean, this statistic, I almost can't believe, but I checked a lot. Kept checking. The data from the Substance Abuse and Mental Health Services Administration, SAMHSA, show that in 2022, 94.8% of people with a drug or alcohol use problem in the past year, quote, did not seek treatment and did not think they should get it. That's an enormous number. Now, to be fair, we use the term substance use disorder. It's the proper term to use. But if you look at the criteria, there are 11. It's a checklist. And in the old days, we used to have substance abuse distinct from what's called dependence, which is really another word for addiction. And I actually thought that was much more helpful. Because it at least gives a sense that there are gradations of severity. Now, to be fair, what abuse meant was that you used drugs for 6 months, there's always a time dimension, and you got in trouble. You drove drunk, you were having trouble at work, you were fighting a lot with your spouse, but you weren't necessarily using in a compulsive daily manner. So it could be you're a drunk driver, that's incredibly dangerous, but it's still not the same phenomenon as someone who is addicted. And so substance use disorder lumps everybody in together. It lumps in fact, they have 3 gradations. They call it mild, moderate, and severe. Out of those 11 criteria, if you have 1 to 3, then you're a mild, and so on. But I think it's 8 to 11, and then you're severe, which in the old days we called dependence, which itself is confusing because it's not physiological dependence. It's another word for addiction. So I think we should separate those things out. So when it comes to behavior change, you can always hear the word denial. But again, that's characteristic of anyone who doesn't want to change a behavior, and in large part because, yeah, sure, it often these things are rewarding on some level, they feel good, but they also serve a purpose. And I'm a big believer in the self-medication model of addiction. And that's why people go through such lengths to minimize the impact of their behavior or to justify it. It's because it's too painful to acknowledge how much they're hurting other people and themselves. So what do I mean by serve a function? Well, people use drugs in a destructive way, not use drugs, because if you can control your drug use, then you're not a problem. Maybe you're a problem in that you sustain an illicit industry, but you're not sort of behaviorally a problem. But by definition, everyone we're seeing is someone who can't control their drug use. Why do they? In what way does it serve them? Well, these folks with severe drug problems really have two levels of problems. First, they're in situations that lead them to find drugs helpful. Either they are going through some kind of chronic psychic pain. That can be anything from, if you read any addiction memoirs, the theme that always comes across is just pervasive and corrosive self-loathing. There are people who just are so socially, sure you could say they have a social phobia, but it's more pervasive than that. They really don't know how to interact. They don't know how to feel comfortable. They feel empty inside. Fill in the blank. Maybe they've been abused and just have harrowing, persistent memories of what happened, or they just don't want to feel anything at all. And they prefer to be a little oblivious, which can help you get through the day. So this is why these drugs are hard. There's one really important reason why they're so hard to give up. And you often hear the phrase, no one, I think you mentioned it the other day, no one wants to become an addict. And yes, of course that's true. What they don't want to experience are the ravages of their addiction, but what they do want is the reprieve that these drugs allow them. And what happens, over the consequences of meeting that desire for the reprieve, they build up, just as they do for any unwanted behavior, for spending too much money, for gaining weight. Again, these are all, repetitive behaviors that work, almost adaptive for some people in the short term, and then they then they sabotage your life. So no one wanted those, problems anyway, but those problems meaning being overweight or being broke or being addicted. But, like so many of life's burdens, they kind of arrive, incrementally, and then suddenly the spender or the eater or the addict is in real trouble, and they find they can't stop, or they don't want to stop. But it's out of desperation, in my experience, that they don't want to stop. And so there's a real emotional logic, to addiction. And I always feel like I have to say that because I think there's medicalizing it too much. It can be a double-edged sword. We should medicalize it to the extent that these medications help, but we can't medicalize it so much that, as I said before, we expect those medications to do everything, or even even clinical intervention to do everything. I have more to say. Is that okay? Because we have a lot of time.
Yeah, go ahead. Go
ahead. But other reasons people don't want to stop is because, more immediate reasons, really, in a sense, or ones they're even more conscious of, is they don't want to go through withdrawal. This is very unpleasant. And they don't want to go, and then in the context of withdrawal, people experience intense craving. So that's just something that's fairly, as I say, immediate. I don't want to go through this. And this is where the medications help out. They're not always done well enough to prevent those, to manage the withdrawal early on. I mean, buprenorphine, people don't always get inducted in the most efficient way. That's a fixable thing, but I've seen that not work so well. And another reason for not wanting to relinquish the drugs is what I was talking about before, is that, not only do you take the anesthetic away from the problems you have, you take it away from that secondary layer of problems you have, which are the ones you created during your whole career of addiction, which is the fact that now, maybe you have AIDS, maybe you have HIV, maybe you've completely alienated your family, you've lost your job, and then when you're, if you're a real hardcore, horrible things happen to you. You get, if you're a woman, you probably get sexually abused, if not, raped along the way at some point if you're homeless, and you get beaten and you get betrayed, and then you have to deal with the betrayal that you have inflicted on you. It's a horrible consciousness to want to encounter. So why would anyone want to stop using drugs if that, to some extent, really is a salve for those emotions? So that's tough, and that's why leverage is so important. And if you can, if there's a reason to bring in, I know this may sound harsh, but either the criminal justice system or some kind of monitoring system, and they can make treatment a condition of whatever, getting your kids back, or not being more deeply involved with the criminal justice system. These are really good things. They're really I call them like benign paternalism, therapeutic coercion, that kind of thing. They're not punitive. They're a way to help someone stand still so they can begin to change their life. So now, why is retention so difficult? Well, I mentioned a lot of those things, but you also have to remember that even when you get into drug treatment, the medications are fantastic. Methadone, buprenorphine, which are basically replacements for opioids. Even the GLP shows some promise at reducing craving, which is highly destabilizing for people. So that's really important. But there's often a big period between, okay, I feel a little better. So if I feel a little better, several things can happen. One, well, maybe I can handle my drugs after all. And that's why folks leave, because they still find them very comforting. Then people will, sort of be in that period where they feel a little better, but they don't feel, certainly, and they couldn't feel well enough to kind of live the kind of productive life that we want them to. And so, I mean, we all take for granted, we know how to live, and a lot of people who've been involved with drugs for so long really don't know how to do that. They don't trust themselves, they don't have a social network that's reliable. Most of their other friends use drugs, so they have to either abandon those friends, and then it could be very lonely because they burn so many bridges with their family. So it's no surprise that people want out. And then I'll just close by saying, well, the medications, you mentioned them all. I'm a big believer in contingency management, and the key words there are swift, certain, and fair, so that if you're doing this in the context of other patients, they see everyone largely treated the same. Because there's nothing like unfairness to undermine the credibility of your treatment program. And if it's in the context of a criminal justice system, it's not severe. You don't have to be severe in terms of contingencies or sanctions, consequences. You just need the right timing. You have to have a consequence that is very soon after the behavior, even if it's a bad behavior or it's the good behavior. It's the one you want to reward. You have to link. A person has to link. I mean, this is behavior 101, but and that's not easy to do in a lot of these programs. There's a lot of bookkeeping, a lot of paper, a lot of when did that person give their clean urine? Well, you got to get them something tomorrow, and that's not. It can be done, but it's not always so easy. So anyway, the drugs are important for keeping the craving and the withdrawal at bay, but for shaping behavior, the contingency, payment is an interesting species. It's not really a contingency, but it's a way to shape behavior for sure. Ultimately, I think this can also be tough because you need good treatment programs, is to make the treatment itself kind of rewarding. Because ultimately what people need when they had serious addictions, there's a lot more connection with other healthy people. So they need social networks, they need a sense of purpose, which in the case of moms is like a built-in purpose, because almost every woman wants to be a good mom. So that's a real that gets you already off the starting line, and folks need to figure out how to solve the problems that are external to them, and some of them are really hard, like just negotiating these systems. I mean, obviously, if you have good social workers, they'll help them, but they can be very hard. And I mean, you've been to the DMV. We'll multiply that up by 1 million on dealing with other service agencies that are really not that responsive. I mean, it just kills me when patients say, well, I called this number and no one even called me back. It's just painful to hear something like that. So that's hard. They have to form a sense of a future plan, but again, with the kid being the focus of it is sort of, again, a built-in boon to that. And then they have to learn how to solve internal problems, which often boils down to developing a strong locus of inner control as opposed to the world and everything. I'm being sabotaged from without, which is often really true, and you don't want to gaslight people. You have to acknowledge that is sometimes true. But it's to learn how to do that yourself and to learn how to handle very difficult emotions and control impulses. And it's really hard. So no one should really be so surprised why we can always do better, but we'll never do, I don't think we'll ever do great, but we can do a lot better. Yeah.
All right, well, on that hopeful note. But Alex, I think what I wanted to just start by asking you is if you could drill down a little bit into what this looks like on the ground. So particularly with the GLP-1 drugs, like how are these being offered to people? What's the mechanism for determining if they're eligible? And how are you doing this kind of accountability, making sure that they're taking them? Are the financial incentives there for that? Just tell us a little bit more about the concrete details there.
Yeah, so today the GLP-1 drugs are approved for obesity and diabetes and maybe some other indications on the way. So unless you're somebody who so happens to be receiving one for those reasons and also has an addiction issue, you wouldn't otherwise have access to them. And so the work that's been done thus far has been small clinical trials. Given the, I think, promising results that's been shown, I think part of what's imperative for us is just to figure out a way to figure out if these things are for real or not, and then to get to market as quickly as we can. As far as the incentives, so that work is thinking about on both the psychiatric side as well as the longer-acting medicines for opioid use disorder. There's long-acting medicines for both things like bipolar disorder, schizophrenia, as well as opioid use disorder, a medication called
So I'm just sorry,
Sublocade.
but just
Yeah.
to get back to GLP-1
Yeah.
drugs for a minute. So
Yeah.
are they currently in use for this, or is this a study that you're going to
That's
be
right.
doing? And
That's right.
And are the only people eligible for it people who are
No.
okay?
Right.
Sorry.
Right. Yeah, no. Sorry. Thank you for redirecting. So the idea would be, can we run a large-scale clinical trial
Okay.
in partnership with the VA, but also I think we're looking at Pittsburgh for some of the populations where we're seeing negative outcomes from addiction, like child welfare, like homelessness, where we think we can make some population health improvements. And so the idea would be to stand up clinical trials based off of those findings, and then see if these things not only are reducing things like consumption, but are they actually reducing child welfare involvement? Are they reducing problems related to homelessness, violent crime? So a huge share of why people show up in carceral settings like the jail is due to reasons related to addiction. And so I think in Allegheny County, with the data that we have, what we're hoping to do is to stand up these trials, but they're still very much in the design phase today.
And you're using, as I understand it, you're planning to use some money that you've gotten through settlements from the opioid lawsuits.
Yeah, that could be one way to fund these things is through the opioid settlement fund. So jurisdictions nationally have gotten money related to settlements against actors in the opioid epidemic, including Purdue Pharma and others. That money can be used quite flexibly for individuals with opioid use disorder. So it's very much an allowable expense to go out and, I think, experiment with some of these novel techniques or things like contingency management. So paying people to hang with treatment. That's something that we've done in Allegheny County because we talked a little bit about stimulant use disorder. There are no medications. Things like rewarding people to stay abstinent from drugs is the gold standard of treatment if you're addicted to cocaine and methamphetamines. And so absolutely, that is a very viable source of funding, as well as philanthropy. And I think my sense in talking to philanthropies nationally is that a lot of them have stepped away from funding work in addiction because they have somewhat given up hope that there are effective solutions. And I think I don't despair as much, and I think that there's opportunities to actually tap into those sources to scale some of these innovative things.
Yeah, that's nice.
I know when you're doing clinical trials, you obviously have to make them clean because you have to control for all your variables except for this one thing.
Right.
And the more variables you add, the harder it gets. But I want to amend my ending. Maybe it wasn't enthusiastic enough. I think that I could be wrong. There could be something in the literature I missed, but I don't think anyone has done all four things at one time. And I don't even know if this is your plan, but it would be really fascinating. And I even though that HEAL study was not that you'd mentioned before that wasn't good. But if you had the medications, which again is for alcohol and opioids, as you said, there's nothing for stimulant use for cocaine or methamphetamine, but the medications where they exist, so that's one. The other, which I skipped over, is relapse prevention, which is a form of cognitive behavioral therapy where people learn it's really an exercise in Pavlovian parsing of your problem from a Pavlovian standpoint. What triggers you? What are the conditions to your craving? And the classic, of course, is people, places, and things, but it's often also internal states, kinds of things. I remember I had a teacher once who used cocaine, so whenever he would go to the old days chalkboard, so the white powder was very provocative to him. So that was, and people do have to become very self-observant, but that's what relapse prevention is about. So you learn these strategies for basically putting something between you and the objects or experiences or situations that provoke craving, and then when that fails, because sometimes it will, how do you handle craving? So that's huge, and that's actually, there's a lot of manual-driven work on that. You're probably familiar with that. Yeah. So, and then 3 is contingencies, and then 4 is leverage from some kind of outside instance. To have all 4 of those working at once, I can't imagine you wouldn't get a significant increment in progress. I don't know, but that could be a very exciting approach.
So Ron, I wanted to ask you about, you mentioned the sort of question of the workforce here, and how you would have a child welfare system interact with parents who need these kind of services. There is a big, shortage, obviously, of workers in the child welfare system. They tend to not have very high skill levels in a lot of areas, and we're not compensating them very well, and all these problems. What do you think is the sort of best approach to think about or to teach people how to handle parents who are suffering from what are some pretty complex needs?
Yeah, I mean, in my experience, I would say that it's hard work and that there isn't a silver bullet, in fact, in retraining a workforce to think differently about addiction and to offer different solutions. I think it takes time. So when we introduced evidence-based models as an alternative to placing kids on delinquency cases back in 2006, we spent a lot of time educating the provider community, the judges, the prosecutors, the defense attorneys. It isn't quick, and you have to be open to taking the critiques and be prepared to answer for them. With a child welfare workforce, I think ultimately there's a real interest in solutions because their work is very frustrating, especially with dual diagnosed, so both dependency on a substance and a mental health challenge. Those feel to workers intractable. So I think there's an openness. When I talked about operability, often you'll hear child welfare folks talk about this pile-on, like we just add more to what a worker needs to do. We don't ever take anything away. The value of the innovations you're talking about are that some of that tremendous frustration would be taken away. In other words, there's an answer. And we've seen that with the introduction of evidence-based models in the preventive world, where workers feel really effective by using something that's been demonstrated to work and then works. So I think, I think that the fact that child welfare workers are undervalued is a challenge for us. I think that as long as child welfare affects mostly poor people, which it does in this country, it's hard to get people to be compensated. Naturally, the cost of not treating these parents is that their children will remain in expensive foster care and likely not have great outcomes. So.
In a few minutes, we're going to turn to audience questions. So I just want to make you aware that if you're on the live stream now and want to submit questions, you can send them into my colleague, Abigail Wallen. It's Abigail, ABIGAIL .Wallen, WALLEN @aei.org. And we'll be able to answer those. So if you send them in now, we'll get to them in a few minutes.
Can I ask a question after you've asked your...
No. I was just going to ask you, Alex, whether you have had this experience, whether you've seen workers respond to these kind of different policies where they feel like they are being more effective, and whether that's helping morale maybe.
Yeah, not sure if it's helping morale, but one thing that we have seen is that we have been able to take some of our opioid settlement fundings and fund this contingency management pilot for individuals that are dealing with stimulant use disorder. And that's just a particularly difficult situation, again, because there are no effective treatments in terms of medications today. And what we've seen is that there's been a sharp rise in terms of referrals from child welfare into that pilot. And so there's been good take up. I think that the sort of the proof of the pudding is in the eating as far as how the outcomes are coming out with that. But I think that, to Ron's point, absolutely, that there is really a hunger and a desperation. And when you think about child welfare, I don't know, I'm a parent, and you just sort of think about like what you wouldn't do for your child as far as behavior change. And the fact that that's not happening, I think, isn't an indication that the parents aren't loving or well-intentioned. It's often just the size of the problem. And so I think that's 100% true. And you don't just see that with child welfare caseworkers, for example. You see burnout and concerns about people working in emergency departments. Like, are we doing anything for these folks? Do we have effective treatments? Are we actually making progress? And I think that's a huge concern, and one of the reasons why we have to stay focused on improving outcomes here.
I've definitely heard that from some folks recently about the kind of Narcan approach to dealing with some of the overdoses, how many times you see people, revived in this way, and the feeling that this is not a real solution to this problem. But it does seem to be sort of from the messaging that, every radio ad you hear is, the answer is we all need to carry around Narcan. I know you want to add something, Sally, but I want to ask you too, you mentioned that you don't see these methods as punitive. But that's certainly the response that people, I think, often have to the child welfare system, which is, you're taking away my kids to punish me, and the way you're sort of using this is as a lever to get me to change my behavior is mean. I mean, I shouldn't say, but is punitive, and it's unfair. I think people who have experience in the child welfare system, I think sometimes see it that way.
Oh, you mean the workers see it that way?
No.
Well?
I'm talking about families who are involved in the system.
Yeah, well, that's why more opportunity to spend all your settlement money is on treatment programs where the moms and the kids can be together. Yeah, those are. I remember we visited one once. I think it was in Lexington. Those have been around for a while, and that is one answer to that problem. Yeah, please.
I was just going to chime in too. I think there has been research by Jason Gross and I'm forgetting the other colleague of co-author of his, that are looking at the impact of having a less lenient child welfare caseworker. And they find very strong impacts in terms of getting families hopefully to take up services in ways that they wouldn't otherwise. And so this view of child welfare is sort of purely punitive, I don't think sort of stand scrutiny to the data, because when you think about those families, what they're sort of finding is that these marginal children, so the ones that we're uncertain about removing or not, let's say, seem to benefit a great deal from that period, in part because child welfare is helpful to families to make the investment so that when the child is returned to them, that they're in a good position to parent. And that has important long-run impacts in terms of things like criminal justice involvement for those children. And so I think that's too narrow of a view to think about child welfare from that lens.
That's Jason Barron.
Sorry, Jason Barron and Max Gross. Sorry,
yes.
I
combined them into one
do a
person.
portmanteau.
Yes.
Sorry, I apologize to both of them.
That's totally fine.
Yeah.
Okay, well, we're going to open it up for some questions. Does anyone in the audience have questions? Because I have lots more questions. All right, we're going to let you think about some more.
I can ask my question.
Oh, yeah. Oh, I'm sorry. No.
That's fine.
I cut you off. Go ahead, Sally.
So Ron, you had you seem to allude to the fact. I mean, there are so many things that the child welfare workers struggle with, but it made me wonder what do you think some of the greatest misconceptions about addiction are among the workers?
I think many workers are young and they don't last a long time, so they haven't had that much life experience. So I think that they sometimes can minimize the addiction. And frontline workers have a tendency to want to root for the parent, to want to see what's best about this parent and why you shouldn't remove their child. And so I think that sometimes on the part, there's not a deep enough understanding of the impact of addiction on parenting, especially young children. So, I do think that our workforce is required to know a whole lot, a little about a whole lot. And addiction is clearly, along with physical and sexual abuse, family violence, addiction, they're like key areas that a child welfare worker really needs to understand. And I think that's hard with addiction.
So we do have a couple questions. So one is sort of about the politics of this. So I guess my question is probably, what are some of the challenges you faced internally? But this person asks, what are the political concerns around utilizing these drugs in a child welfare context? I guess the GLP-1 maybe. Are there barriers to gaining support for these interventions in terms of, we've been talking about kind of the workforce, kind of the people on the ground, but what about sort of going up to higher levels of government, your superiors or folks in the legislature? What do they think?
So I think that there's probably two schools of thought on this. One would be, I'd imagine there's a cohort of people who would go, why are we going to treat parents and child welfare as guinea pigs? But one of the interesting responses that I've gotten from this is from our former head of behavioral health in Allegheny County, who was saying he'd been begging people for years to do trials on people with HIV/AIDS in settings like homelessness because he thought that they were underserved and that they were understudied as a group. And these groups bear disproportionate amounts of the cost. So I think it'd be a real shame if what we did here is, I think, Sally, to your point, there are gradations of addiction. If your addiction is so heavy that you're coming to the attention of the child welfare system and having a child removed from the home, that seems to me to be a first order policy problem, not only because of the foster care costs, but because of the personal and emotional and societal costs that we all bear. And so I would imagine that there would be a great deal of support for that, but I do acknowledge that there's going to be a couple of schools of thoughts on this one.
What's Ron or Sally, do you have any?
I mean, so as you know, I come from New York, and especially in the city, anything that can be construed as diminishing people's civil rights will be construed as diminishing people's civil rights, but that's New York City. I think New York State is probably more likely to be receptive of a solution for a problem that everyone knows we struggle with. Any effort we can make to support a parent, and with court, it's sometimes coercion, I think folks are interested in. I think you have to make the case, right? You'd have to demonstrate. For example, there's a lot of anecdotal, I guess, evidence that these drugs like Ozempic, people who are on them immediately talk about how they don't want to drink as much. It's there. So if that could be demonstrated, I think there would be an understanding in some ways because the whole population is engaging with the Ozempic drugs and hearing so much that they kind of have a good spin at this point, which is helpful.
Right. Right, and so, great. It depends on sort of how you want to spin this narrative. So if the other way would be, it's not fair that all these rich people are getting to take Ozempic and we're not getting a piece of that. The other question.
I think in New York City, the zip code that has the most Ozempic users is the Upper East Side. I think that's been shown, which, there you go.
I'm sure that's true. The other question here is about incentives and on the federal level or on any kind of governmental level for this kind of innovation. So you mentioned, we talked about the money from the lawsuit settlements. Are there other funds available, either public or private, to encourage this kind of innovation?
Yes, so one of the reasons why the VA has been so innovative on things like contingency management is because they're able to step outside of anti-kickback laws and other restrictions that apply to other jurisdictions and other healthcare systems. And so what states have done to get around some of the use of financial incentives in different settings is to apply for these so-called Medicaid 1115 waivers that are for innovation from CMS, and those would sort of fund some of these innovative programs as demonstration pilot projects. I think Sally might be able to talk more about them, but you're starting to see that in places like California, in places even like Montana. So it's really not just large populous states, but even smaller rural ones where I think that sort of money can be applied in smart ways. And then the other thing I would say is, to Pennsylvania's great credit, they're incredibly flexible and generous with how they fund child welfare. It's not just for caseworkers or child welfare services, it's for prevention and help to families broadly. And so, there are probably opportunities out there for people to think expansively about the funds that they get and braiding them in interesting ways here.
And I just wonder, I remember the graph you showed is sort of that the uptake on some of the medications that have been available has remained largely flat.
Yes.
But you mentioned that one of the benefits of the GLP-1 drug seems to be that there are fewer side effects.
Right.
And so do you expect that is going to result in sort of more positive benefits than maybe we've seen with other medications? Yeah. Also with, antipsychotic medication, you were talking about sort of, the mental health, separate from substance use, whether the side effects are also sort of providing a disincentive for people to take up these drugs.
I think that there's absolutely a story about that you could tell, both because of the story that Ron said of like, hey, the people on the Upper East Side are taking it, Kim Kardashian's taking it, Oprah's taking it, like, this is great. I think that the other reason, though, is I went and interviewed some individuals at a homeless shelter that we helped to fund, and several of them had mentioned to me that coming off of buprenorphine and discontinuing buprenorphine, as far as that withdrawal, was way worse than what they had experienced with heroin. And so I think those sorts of things, I think, matter kind of a great deal here for sure.
I'm sure there are lots of people studying the most effective ways to start weaning people off this. With methadone, it's actually pretty easy, but it can take a year. If you've been on methadone for a while, you may come down, let's say your dose is 80 or 100, which I think is about the average, or maybe slightly high, but it's like 1 milligram a week at most. So these things take a long time, and I don't think they've perfected the kind of analogous slow taper for buprenorphine. I was going to ask you, what are the opportunities for peer intervention? When it comes to sort of straight addiction, they're everywhere. People who are recovering, they're often counselors themselves. But to the extent that there are women who, and there clearly are, who have been helped or stopped on their own, but know that a lot of folks can't do that, and they need these interventions, that for them to be part of the collection of helpers, surrounding each patient.
No, I think it's spot on. And you had mentioned the point earlier about, hey, like, this isn't just a medical problem, because at the end of the day, a lot of people's social networks are disintegrating. And so if you think about, can peer supports actually be a way to start to rehabilitate that? I think every jurisdiction in the country, and Ron, maybe you can speak to this too, like, everybody's reading Bowling Alone, everybody's thinking about loneliness among kids, sort of fraying social fabric in our country. I don't know that we can't send people back to church. Maybe contingency management to send people back to church. Like, how do you build social capital in those settings? I think is incredibly difficult, but maybe peers, it could be an incredibly compelling idea. And healthcare systems love the idea of certified peer specialists, and so in many medical settings, those are used in droves. I think thinking about that expansively is a really interesting
and navigators to help you get through these Byzantine systems.
I think navigators are different than peer supports.
They are. Yeah.
I think
add another one.
Yeah, I think peer supports are helpful. I don't think that peer supports are an answer or a treatment in and of themselves. I think they're tremendously helpful in encouraging people to know that there's another side to this story. I do think that for families in child welfare, in my experience, that are confronted with this constellation of issues, there is tremendous social isolation. Yeah. As you pointed out, you have moms who are basically not having a relationship with anyone in their families because they have axed all of those relationships. And at least in New York, appropriately, it's difficult to have a child removed, but when we end up removing, it is often someone who is socially isolated. And an important question to ask before a child is returned is, who are you going to call when XYZ happens? And you got to get an answer out of the person. And sometimes it's hard because that social isolation is lasting with people who have been addicted, as you were describing, for long periods of time.
A couple of maybe more technical questions here. So what triggers a tox screen in Allegheny County? Is that typical in Pennsylvania? I don't know if this is specifically about, you were talking about the Hello Baby model, about whether a positive tox screen for a newborn or a mother, but what triggers a tox screen in Allegheny County? And it asks, does the county get pushback for racial profiling? So I don't know if you want to answer kind of the tox screen at maybe different levels of the system.
Yeah, it's actually a great question about like what exactly are the criteria and what are they looking for. I actually don't think that I have the answer off the top of my head, but just to clarify on the Hello Baby piece, there is no connection between substance use disorder sort of diagnoses or a positive tox screen and involvement in the program. It's totally universal. The idea is there are many risks to families that we can't see in terms of that moment of birth. How are we going to get out there and offer solutions at scale? I think on the racial profiling question might be about the algorithm itself. Is that your interpretation?
I'm just trying to figure it out. But I guess maybe the question is like, how do you know who to test? And is there a concern that there's bias when you're deciding who to test, I guess, which could be at birth or it could be any point, I guess, in an investigation.
I think that that's a totally fair question, and Jason's work in terms of home removal finds that there is racial bias in some of these decisions, and so I don't know that I have hard data on how it is, but again, because you don't have a universally observed measure of substance use disorder, and you even have gray in terms of what that means and does it actually place the child at risk. Anytime you're introducing that degree of discretion, I'm sure that introduces the opportunity for biased decision making to arise.
Yeah. You don't really have the upstream person here who deals with them. By the time they get to you, things are really bad.
Right, but even, I just interpreted the question, even just in terms of like the referrals to level of care assessments and things of that nature, I think that's right.
So I guess maybe a last question for all of you. I mean, what would you like to see kind of happen next in this area? What do you think are the next steps? Like Ron, for instance, if you wanted to see, New York City adopt some kind of program, like what do you think is the next step there? And for all of you, kind of just thinking about the future. You don't have to tell me whether you're optimistic or not, Sally. But just kind of trying to understand if any of the people watching it, and I know we do have a lot of people from different states who are looking at this, what they might think about trying next.
Oh, you're asking? Oh, okay. Well, again, since I don't run these systems and I don't have much experience with them, I'll just answer from the standpoint of someone coming from that academic background, which is, I want to see that study with all four. I mean, you'd have to have a lot of arms, and this, it would be tough, or even just 3 of them, or even maybe just 2 of them at what? I assume that was going on, but maybe not. Just to have contingency management with medication. I know those studies have been done, but you need more, and you need them with different populations, and so that's what I would vote for in terms of collecting data, but at the research level that way.
Ron?
I think I would want to see a public-private partnership to try to pilot something in New York. I think there's definitely an appetite for innovative treatment. I think that the challenge for the government is always how can we offer this to this group and not offer it to that group, but I think we could overcome that. So in terms of next steps, I'm very eager to see what Allegheny County finds. And I think that, it doesn't just have to be Allegheny County. I think there are other counties, jurisdictions that should at the same time be trying the same thing because, different communities always say, well, it's not going to work for New York just because it works for Allegheny. Yeah. So it would be good to try to shake it up a little bit and get a diversity of experiences. But clearly, there's promise here if you're a layperson like me, because addressing how the brain sort of responds to the need for whatever it is, has definitely been, we've learned a lot from these drugs. It's clear.
Yeah. I come back to Justice Brandeis's conception of state and local government being the laboratory of democracy. And so I second Ron's point that more than any specific intervention, the thing that I think is intolerable is just to capitulate on these issues. And I fear what we've done with alcohol in this country, where we haven't raised the federal tax on alcohol in over 3 decades. It doesn't seem to me that there's a great deal of innovation medically or otherwise. That becomes the situation with opioids and stimulants, where we just haven't had a principled way to search through the potential solutions, test them rigorously, get evidence. And to Ron's point, if New York City and Pittsburgh are doing different things, that's totally fine. I think that that's exactly what you want. You just want ways to, I think, quickly iterate and learn about how to make effective progress here.
I mean, this is human services, and I think it's important to acknowledge we aren't usually at the cutting edge. So
we're trying to change.
And you've picked the hardest population.
I always like to think about IT, and we're catching up. We're like in the 70s,
Yeah.
and so we have to keep that in mind. I do think in the post-pandemic world, there's more opportunity because everyone was confronted by the emotional impact, and it is clearly a lasting impact. So I think there's opportunity.
Yeah, great. All right, well, please join me in thanking our panel today.